Welcome to the deep dive. Imagine a medical intervention that costs literal pennies, requires no electricity, and is widely considered the most important medical advance of the 20th century. It isn't a gene therapy. It's just a simple combination of salts and sugar. Today, we are exploring oral rehydration therapy based on a comprehensive stack of clinical notes. Our mission is to unpack exactly how this deceptively simple solution prevents global diarrheal deaths.
It is, without a doubt, one of the most elegant biological loopholes we've ever managed to decode. And, the global stakes of understanding this mechanism simply couldn't be higher.
Yeah, I want to start exactly there with the stakes, because I think there is a profound disconnect depending on where you are listening to this right now.
Right.
If you live in a place with reliable tap water and, a pharmacy on every corner, diarrhea is mostly just an inconvenience. You get a stomach bug, you drink some ginger ale, and you recover. It's annoying, but it isn't terrifying. But the clinical notes we're looking at today paint a completely different picture. Diarrhea is the second leading cause of under 5 mortality globally, once you exclude neonatal mortality. Second only to acute respiratory infections.
Wow.
We're talking about an astronomical scale of loss, primarily in resource-poor countries.
And that context is absolutely foundational for you listening, because it explains why oral rehydration therapy, or ORT, as we'll call it, isn't just a convenient alternative to a hospital visit. It's the frontline defense.
Right.
Let's really visualize what resource poor means here. It means you might be in a rural clinic hundreds of miles from a major hospital. You don't have a reliable supply of intravenous fluids. You don't have sterile needles. You don't have the trained personnel required to safely insert an IV line into the collapsed vein of an infant. And honestly, you might not even have electricity. If the only way to save a child from severe dehydration was an IV line, the mortality rate would just be catastrophic.
Yeah.
ORT bypasses all of that infrastructure. It's a simple prescription for dehydration, specifically the rapid dehydration associated with pediatric diarrheal diseases.
Okay, so let's look at the actual clinical definition in our notes, because right off the bat, this is where I realize how much I misunderstood the treatment.
Oh, yeah.
Yeah, the definition of ORS, oral rehydration salts or solution, is defined as an increase in administered oral fluids and continued feeding. Wait, let's unpack this.
Okay.
The clinical definition isn't just about a magic liquid, but explicitly includes continued feeding. Why is that inclusion so critical?
Because for generations, the medical community and, popular culture labored under a very dangerous myth.
Yeah.
You've almost certainly heard some version of it: starve a fever, feed a cold.
Right, sure.
Or the directive to rest the gut. The prevailing logic was that if the gut is inflamed and producing diarrhea, you should stop putting things into it. Let it rest.
I mean, I'll admit, that sounds intuitively right. If a car engine is smoking, you don't keep flooding it with gasoline.
It sounds incredibly logical, but biologically, it is entirely backward. Your gut isn't a mechanical engine. It's a living tissue. Let's zoom in on the lining of your intestines, which is made up of these cells called enterocytes.
Okay.
When a pathogen causes diarrhea, it physically damages that intestinal lining. It strips away the cells. Now, to repair that damage, the body requires immense amounts of energy.
It needs calories.
Exactly. It needs calories. If you withhold food from a child who is already losing massive amounts of fluids, you are essentially demanding their cellular construction workers rebuild a demolished building, but refusing to give them any breaks. You're starving the recovery process.
Wow. So by mandating continued feeding, right in the definition of ORS, the guidelines are saying you cannot just pour water back into a leaking bucket. Rebuilding the gut wall is a prerequisite for survival.
Exactly. You treat the dehydration with fluids, but you treat the underlying tissue damage with continued feeding.
Which brings us to the actual fluids and how they interact with that damaged tissue. To understand why feeding and specific fluids work, we have to look at the microscopic battleground of the intestinal wall, the physiologic basis.
Yes.
And as I read through these notes, it honestly feels like a biological heist movie, where the invading pathogens lock the front door, but the body has a hidden back door.
That is a phenomenal way to visualize it.
Yeah.
But to understand the back door, we have to establish the normal traffic through the front door. Every single day, a healthy human gut processes about 8 liters of digestive juices.
8 liters? That's what, 4 large 2-liter soda bottles of fluid just sloshing around inside you every single day? Where does that even come from?
It comes from your own body. Saliva, gastric acid, bile, intestinal fluids. You secrete this massive volume into your digestive tract to break down food, but you don't lose that fluid.
Right, you recycle it.
Exactly. Your intestines reabsorb almost all of it, pulling the water and electrolytes back into the bloodstream. Pyrethroid disrupts this entirely. The pathogens paralyze the mechanisms that allow reabsorption.
So those 8 liters just flush straight through the system.
Yeah.
And the immediate instinct for any parent is, well, they are losing water, so make them drink more water. Or they're losing salt, so I will give them salt water. But our notes are emphatic here. Giving just water plus sodium by mouth has no beneficial effect.
None at all.
In fact, the normal mechanism by which sodium is absorbed is completely impaired by the diarrhea. So why does salt water fail?
To understand that, we have to talk about osmosis. In the human body, water follows sodium. Wherever sodium goes, water is passively dragged right along with it. Normally, you have millions of microscopic cellular pumps in your intestinal wall grabbing sodium out of the gut and pumping it into your blood.
And the water follows.
Right. But the pathogens that cause diarrhea destroy those specific sodium pumps.
So the front door is locked. If you drink salty water, the salt has no way to cross the barrier. It just sits there in the intestine. And the clinical notes point out a terrifying consequence. Excess sodium in the intestinal lumen actually causes increased secretion of water and worsens the diarrhea.
This is where a misunderstanding of biology becomes fatal. Think about our rule, water follows sodium.
Right.
If you pour salt water into a gut where the pumps are broken, it becomes a highly concentrated puddle of sodium. Because of osmosis, that salt acts like a powerful magnet, actively pulling fluid out of your body's tissues and into the intestine.
You're trying to rehydrate them, but you're actively dehydrating them faster.
Exactly. You are literally pulling water out of their blood.
That is horrifying. Okay, so the standard sodium pump is destroyed. Enter the back door active transport.
Yes.
The notes specify that sodium absorption in the small bowel is coupled with small organic molecules, things like glucose, neutral amino acids, dipeptides, short-chain-free fatty acids. This enhances sodium and chloride absorption, and then water follows. But the absolute star here is the sodium-glucose transport. And crucially, this specific co-transport mechanism is maintained during diarrhea despite intestinal villus damage.
That's the key.
And the ratio is exactly 1-to-1. 1 molecule of glucose co-transports 1 sodium ion. So it's like a nightclub with a very strict bouncer.
I love this analogy.
Right. So sodium can't get in through the door on its own because the VIP list got ruined by diarrhea. But if sodium shows up arm in arm with glucose, a 1-to-1+1 situation, the bouncer lets them both through, and a crowd of water passively follows them in.
That bouncer is a specialized protein called the SGLT1 transporter, sodium glucose link transporter 1. And the discovery of this unaffected co-transport channel was a monumental breakthrough in medical science.
Because it survives the infection.
Exactly.
Yeah.
For reasons involving complex evolutionary biology, pathogens like cholera or rotavirus do not disable the SGLT1 transporter. They wreck the standard channels. But this side door remains intact. If this channel were also destroyed, oral therapy would be impossible. We'd be entirely reliant on IV fluids.
Which means millions would die. Okay, so we know how absorption works. Now we must analyze exactly what the body is losing to understand what needs to be replaced. This brings us to decoding the threat, looking at the stool electrolyte profiles.
Right, the lab results.
Let's read out and compare every single value from the stool table in our notes. Imagine we have 3 stool samples.
Okay.
The first is from a patient with cholera. The lab results in millimoles per liter are sodium 88, potassium 30, chloride 86, bicarbonate 23, and osmolarity 300. Now the second sample, rotavirus. Sodium is 37, potassium 38, chloride 22, bicarbonate 6, and osmolarity 300.
Right.
And the third sample, E-Tech, which is enterotoxigenic E. coli. Sodium is 50, potassium 37, chloride 24, bicarbonate 18, and osmolarity 300.
Sure.
Here's where it gets really interesting for you listening. Look at the sodium difference between cholera, which is 88, and rotavirus, which is 37. Why does cholera drain so much more sodium from the body?
Those numbers illustrate the disease severity perfectly. Rotavirus causes an osmotic or inflammatory diarrhea. It damages the cells, so they stop absorbing fluids. You lose the sodium you are already failing to absorb.
Okay, and cholera.
Cholera causes a secretory diarrhea. The bacterium produces a toxin that binds to the intestinal cells and flips a master switch to the on-end position. It creates a massive secretory loss of sodium and chloride compared to viral causes.
It forces the cells to pump their own reserves out into the gut.
Exactly. That's why cholera's sodium loss is an astronomical 88. This explains why cholera can lead to fatal hypovolemic shock so rapidly if the exact electrolyte profile isn't matched. The patient loses so much fluid and sodium that the heart doesn't have enough blood volume left to pump.
Which brings us to the Alchemist's Guide, designing the compositions of ORS. Because we know exactly what is lost, we can design the exact chemical combinations to replace it. Our notes detail the ideal ORS. It needs to replace electrolytes and fluid completely, be isotonic with plasma, have higher potassium than plasma, and keep carbonate between 30 to 40 millimoles per liter, plus optimal sodium and glucose for transport, and, crucially, it must be palatable.
Palatability is massive. You can design the perfect biochemical fluid, but if a sick, terrified child refuses to drink it or vomits because it tastes foul, your science is useless.
So true. So how do we make it? Let's go through the SSS, the salt-sugar solution. Table salt. 1 leveled 3 milliliter teaspoon, and it notes not heaped, which equals 1.8 to 2.4 grams or 60 millimoles per liter.
Right.
Then sugar. 10 leveled 3 milliliter teaspoons, or 5 cubes, that's 20 to 25 grams, or 80 millimoles per liter, mixed in 600 milliliters of water. And the notes explicitly say 600 milliliters is equivalent to 2 soft drink bottles or 1 beer bottle.
That instruction is just a masterclass in global public health. You can't assume a rural clinic has a Pyrex measuring cup. But almost everywhere in the world, a glass Coca-Cola or beer bottle is manufactured to the exact same volume. It standardizes the recipe globally.
Brilliant. And if they don't have refined salt and sugar, the notes list other home fluids.
Yeah.
Salted rice water, green coconut fluid, salted yogurt, and salted Gary water.
They all provide that crucial mix of sodium and a carbohydrate for the bouncer.
Exactly. Now let's look at the commercial institutional preparations. I'm going to read out the exact values comparing the original WHO-ORS versus Pedialyte.
Okay.
Original WHO-ORS, glucose 111 millimoles per liter, sodium 90 milliequivalents per liter, potassium 20, chloride 80, base 30, and total osmolarity 311. Now, Pedialyte. Glucose 140, sodium is way down to 45, potassium 20, chloride 35, base 30, and total osmolarity 250. But then, in September 2003, the WHO and UNICEF introduced the reduced osmolarity ORS because it reduces loose stools.
Right, a massive pivot.
Let me read all these values. In grams per liter. Sodium chloride 2.6, anhydrous glucose 13.5, potassium chloride 1.5, and trisodium citrate dihydrate 2.9.
And in millimoles per liter.
In millimoles per liter, that's sodium 75, chloride 65, glucose 75, potassium 20, and citrate 10, giving a total osmolarity of 245. The notes mention the WHO-ORS risk was that it can lead to hypernatremic dehydration.
Yes.
So what does this all mean for the person mixing this at home? I mean, 311 total osmolarity down to 245 osmolarity. Is that 66-point drop really the difference between life and death?
It absolutely was. To understand why that 2003 shift was necessary, think of osmolarity like the absorbency of a sponge. A highly concentrated, high osmolarity fluid acts like a dry sponge. It pulls water into itself.
Okay, pulling water into the gut.
Right. The original WHO-ORS had a sodium level of 90. It was designed in the 60s primarily for adults with cholera, who lose massive amounts of sodium, 88 millimoles, remember?
Yeah, we just read that.
But most children globally dying of diarrhea had rotavirus, losing only 37 millimoles of sodium. If you give them the WHO-ORS with 90 sodium, you overload their system. The fluid acts like a dry sponge, pulling water from their blood into their gut, worsening diarrhea, and pumping excess salt into their blood.
Which causes the hypernatremic dehydration.
Exactly. Pedialyte dropped their sodium to 45, optimized for viral diarrhea. But global health needed a universal packet.
Right.
So pediatric medicine negotiated the perfect balance, reduced osmolarity, ORS. By dropping sodium to 75 and matching glucose at 75, they created an osmolarity of 245. It acts like a damp sponge, allowing water to effortlessly flow out of the gut and into the body, rehydrating the child safely.
Such an elegant calibration.
Here.
Now, before we hit clinical management, let's cover Resomol, which is for severe malnutrition. The preparation is standard ORS in 2 liters of water, not T1 liter, plus 40 milliliters of stock potassium chloride, which is 100 milliliters and 50 grams of sucrose. The concentration in millimoles per liter is glucose 125, sodium 45, potassium 40, chloride 70, citrate 7, magnesium 3, zinc 0.3, copper 0.045, and osmolarity 300.
We'll talk about why we use that specifically later, but it's vital to get those numbers on the board.
All right, so having engineered the perfect fluids, we must explore exactly how to dose and deliver them to a patient. The frontline clinical management. The indications are prevention, correcting mild to moderate dehydration, and follow-up after IV therapy. The administration mode is brutal, though. Small volumes at a time. Example given. 1 teaspoon every 30 seconds, and discard unused solution after 24 hours.
It's tedious but critical.
Let's look at the dosage rules for replacing the deficit over 4 hours. Prevention is 10 milliliters per kilogram. Mild dehydration is 30 to 50 milliliters per kilogram. Moderate dehydration is 60 to 90 milliliters per kilogram. And then there's some dehydration, which combines mild and moderate at 75 milliliters per kilogram.
Right.
Then you have maintenance at 100 milliliters per kilogram per 24 hours, and ongoing loss, which is 10 milliliters per kilogram per loose stool. And you have to monitor frequently, hourly or less, watching for overhydration signs like increased respiratory and pulse rate, engorged jugular veins, and increasing edema like puffy eyelids.
Yep.
But I want to focus on that administration rate, 1 teaspoon every 30 seconds. That requires immense patience from a caregiver. Why can't we just let a thirsty child chug a whole bottle at once?
Because rapid ingestion of fluid completely overwhelms those delicate one-to-one sodium glucose channels. The bouncers can only check IDs so fast.
Right.
If a child chugs it, the body perceives this sudden pooling of fluid in an inflamed stomach as a severe irritant. It triggers immediate vomiting, or it rushes through the gut, worsening the diarrhea. You have to trickle the fluid in molecule by molecule. It highlights the profound psychological burden on the caregiver to administer life-saving fluid agonizingly slowly.
Wow. Okay, so standard protocols work for standard bodies. But what happens when the patient's body is fundamentally compromised? This is severe acute malnutrition, or SAM.
This is the toughest clinical scenario.
SAM is defined as a child under 5 with very low weight for height or length, specifically 2 standard deviations below expected. It's hard to assess hydration, and fluid management is incredibly complex. The notes break it into 2 categories.
Let's go through category 1 first.
Category 1 is dehydrated, but no SHOC key. You do slow oral or NG2 rehydration. You use Resimol or half-strength WHO low osmolarity ORS with added potassium and glucose. The dose is 5 to 10 milliliters per kilogram or per hour up to a max of 12 hours.
Right.
Specifically, it says 5 milliliters per kilogram every 30 minutes for the first 2 hours. Average to correct is 70 to 100 milliliters per kilogram. But UT, if you suspect cholera or profuse watery diarrhea, you give standard WHO low osmolarity ORS, normally made, not diluted. So why do we use Resimol, which we noted earlier requires mixing standard ORS in 2 liters instead of 1 for malnourished kids unless they have cholera, where we suddenly go back to the regular strength?
That's because of the delicate sodium balance in severely malnourished children. When a child is starving, their cellular pumps fail due to lack of energy. Sodium leaks into the cells. They have dangerously high intracellular sodium, but low total body sodium.
Oh, wow.
If you give them standard ORS with 75 millimoles of sodium, it's too much salt for their broken pumps to push out of the cells. The cells swell, causing massive edema and rapid heart failure. Resol uses half the sodium 45 millimoles to respect that fragile balance.
But cholera overrides that.
Yes. Cholera's extreme sodium-depleting power is so violent, 88 millimoles, that it completely overrides the malnutrition protocol. If you give Resimol to a malnourished child with cholera, they will die of hypovolemic shock before cellular swelling even becomes an issue. You have to use standard ORS.
That is a terrifying tightrope, which leads us to category 2. In SHOCK, oral is out. You give 10 to 15 milliliters per kilogram IV.
Right.
The fluids are half-strength Darose plus 5% dextrose, or Ringer's lactate plus 5% dextrose, or 0.45% saline plus 5% dextrose. Monitor every 15 to 30 minutes. If improvement in the first hour, like a reduction in respiratory and pulse rate, repeat another hour, then change to 10 milliliters per kilogram per hour of Resimol. But if there's no improvement in the first hour, treat for septic shock. And there's a hypoglycemia protocol. 4 milliliters per kilogram of 10% dextrose water as a bolus. Alternate with ORK 2 hourly. Feed with F75 ASAP.
This is where the clinical examination becomes critical.
Exactly. To manage category 2 safely, clinicians must perfectly distinguish between severe dehydration and septic shock in their examination. A mistake here is fatal. So let's systematically compare the clinical signs across 4 states. Some dehydration, severe dehydration, incipient septic shock, and developed septic shock.
Let's do it.
Watery diarrhea. For some dehydration and severe dehydration, it's yes. For both stages of septic shock, it's yes or no.
Okay.
Thirst. Some dehydration, drinks eagerly. Severe dehydration, drinks poorly. Septic shock, no.
Right.
Hypothermia. Some and severe dehydration, no. Septic shock, yes or no. Sunken eyes. Some and severe dehydration, yes. Septic shock, no.
Take 10 to that.
Weak or absent pulse. Some dehydration, no. Severe dehydration and both septic shocks, yes. Cold extremities. Some dehydration, no. Severe dehydration and both septic shocks, yes.
Right.
Urine flow. Some dehydration, yes. Severe dehydration, yes or no. Incipient septic shock, yes or no. Developed septic shock, No.
Hmm.
Mental state. Some dehydration, restless or irritable. Severe dehydration, lethargic. Incipient septic shock, comatose or apathetic. Developed septic shock, lethargic. And hypoglycemia is sometimes present across all four. Let's look at the sunken eyes. In severe dehydration, you have sunken eyes, but in septic shock, you don't. Yet both have a weak or absent pulse and cold extremities. How does a clinician parse this in real time?
They have to use symptom clusters. The symptoms look identical, but they're caused by different mechanical failures.
Yeah.
In severe dehydration, the fluid is physically gone from the body, leaving the blood vessels empty, which causes the weak pulse. And because the body is desiccated, the eyes sink.
Okay, but in septic shock?
In septic shock, massive inflammation makes the blood vessels leaky. The fluid leaves the bloodstream, emptying the vessels and causing a weak pulse, but the fluid just pools in the surrounding tissues. The body isn't actually dry, so the eyes don't sink.
Wow, so normalize with cold hands means sepsis.
Exactly. You look at
Okay.
the danger zones. A lethargic state is present in both severe dehydration and developed septic shock. So you cross-reference with urine flow and thirst, which are crucial differentiating markers.
The cognitive load on the clinician is just staggering. Okay, finally, let's cover when not to use ORT, the contraindications.
Every treatment has its limits.
Right. Number 1, initial treatment for severe dehydration or hypovolemic shock.
You have these first.
Number 2, paralytic ileus or severe abdominal distension. Number 3, when the patient is too lethargic to drink. Number 4, too rapid rate of massive diarrheal stool volumes, specifically more than 15 millirees per kilogram per hour. Number 5, severe persistent vomiting. And 6, rarely malabsorption syndrome. Let me push back on number 4. If OT relies on the gut's active transport, why is a high stool output rate more than 15 milliliters per kilo per hour a reason to stop? Shouldn't we just give them more ORT faster?
The gut has a maximum absorption velocity. Even if every SGLT1 bouncer is working, they can only process molecules so fast. Once stool output exceeds 15 milliliters per kilograms per hour, it is physically impossible for the one-to-one channels to keep up.
It's a flash flood.
Exactly. The oral fluids will just pass straight through unabsorbed. At that threshold, 4B fluids become absolutely mandatory to save the patient.
Unbelievable. Well, to summarize, ORT is the absolute cornerstone of rehydration. It reduces hospital admissions, reduces the use of IV fluids, massively reduces mortality, and is so easy to administer. All healthcare workers must master its use and teach caregivers to utilize it to increase child survival.
It truly is a miracle of modern medicine.
We live in an era of multi-million-dollar medical machines and AI-driven gene therapies. But as we've seen today, the most globally impactful medical intervention of our lifetimes is just water, a bit of sugar, a pinch of salt, and a biological loophole that stays open when everything else fails. Makes you wonder what other devastating global crises could be solved not with a newer, more expensive technology, but with a deeper understanding of the simple, elegant systems already at work inside us.